Assalamu alaikum everyone. This is Dr. Rafia Shah. Today we'll be discussing about another branch of orthodontics that is called as interceptive orthodontics. As we know that in orthodontics, our concern is to treat the malocclusion. So in interceptive orthodontics, what we do is that we try to detect the problem as soon as possible. And we try to eliminate the problem and prevent the problem to reach to the severity. Means at an early stage, when the problem is developing, we intercept with the problem, orthodontic problem, and we try our best to not allow the malocclusion to reach to the severe level. So we need to detect it early as possible. So we'll be discussing about in detail what is interceptive orthodontics, where do we do interceptive orthodontics, how do we do interceptive orthodontics. So by definition, first of all, before definition, I should explain what is interceptive orthodontics. Then we'll be discussing about all the ways of doing it and its definition. So interceptive orthodontics, interceptive orthodontics, first of all, we try to eliminate a developing problem. Means a problem is still developing, we try to eliminate it at an early stage, at the right time. We cannot wait for the problem to reach to the severity level. Number one. Number two, as I said, we are interrupting with the developing problem. It means we are preventing the severity of malocclusion. When we prevent the severity of malocclusion, automatically you will have more desirable results at an early stage. And this way, the treatment time for the patient will be reduced. Ultimately, the discomfort for the patient will be reduced. So in a nutshell, what did we understand is that interceptive orthodontics is done at a very early stage once it is diagnosed, at a right time to prevent severity of malocclusion. Once the severity of malocclusion is reduced, it means in the end we will have more stable desired results, and due to have early interruption with the malocclusion, the patient will have less discomfort with the orthodontic treatment, as well as the treatment time will be shorter. But for beginning of any orthodontic treatment, we should understand one thing, that we cannot begin orthodontic treatment until and unless abnormal habits of the patient are not stopped. If the etiological factor would persist, it means we will fail to have desirable results, or we cannot begin the orthodontic treatment. Once the patient has stopped the habit, then an orthodontist can plan what way is he or she going to treat the patient, either by means of fixed appliances or by means of removable appliances. By definition, interceptive orthodontics is employed to recognize and eliminate the problem at an early stage to prevent a malocclusion from developing to its severe level. So Again, I need to repeat this, that interceptive orthodontics is done at an early stage when we see that the problem is arising. We try our best to not to allow the problem to reach to the severity level in order to reduce the discomfort to the patient as well as to reduce the treatment time. So what are the steps in doing orthodontics, interceptive orthodontics? Number one, in interceptive orthodontics, when we see that the problem is there, like malocclusion is there, for any malocclusion, for example, these are maloccluded teeth, okay? These teeth, when you see there is a malocclusion or abnormal occlusion present, or maybe the teeth which due to spacing, the teeth are tilted due to early loss of some tooth, the other tooth, adjacent tooth has taken this space. So for any treatment, first of all, we need to create a space to treat the tooth which has lost its own anatomy. So the first step in orthodontics, in interceptive orthodontics, is to gain the space. The space can be gained by different ways. We'll be discussing this in detail. Number two, in interceptive orthodontics, we need to correct anterior or posterior crossbite. Crossbite is said when, for example, as we know that the normal dentition, the upper and lower teeth are arranged in a way that upper teeth are normally ahead of the lower teeth. I'm talking about the anterior teeth right now. The upper teeth are normally anterior to the lower teeth, but when the upper teeth are not placed in such way, then they create a bite that is called as cross bite, as this picture shows. Similarly, there is a cross bite in the posterior region, so that is called as posterior cross bite. Now, another way or another step of doing interceptive orthodontics is eliminate, as I told you, we need to remove the theological factor. The theological factor should be removed. As in this picture, we see a child is having habit of thumb sucking. If we need to treat this child, or we need to treat the malocclusion in this child, first of all, we need to stop the habit of a child. Then another way is maybe there is hyperactivity of the muscles. We need to give muscle exercisers. Then the muscles are hyperactive. We can remove the soft tissue barriers like this, the third molar. This here I have given the picture of a third molar, but if you just take it, if there is a canine which is impacted due to barrier over it, like this is the canine tooth, and there is a soft tissue or hard tissue barrier over it that is not permitting this tooth to erupt into the oral cavity. So we need to remove this barrier to allow the tooth to erupt into the oral cavity. Then it includes resolution of crowding. If the crowding is present into the arch, we need to resolve that crowding. And in interceptive orthodontics, we deal with developing skeletal malocclusion. You see here in this picture, not only the dentition of this patient is ahead, or not only the teeth are proclined, but there is a skeletal problem. The patient's maxilla is also prognathic. So there are multiple ways we treat the patient with developing problem, and that comes under the treatment of orthodontics, a branch called interceptive orthodontics. So as we said here, the first thing we need to do is we need to gain the space. So what are the ways to gain the space? We'll be talking about it in detail one by one. Space regaining. The word regain tells us that the space which was earlier present, that is lost. We need to regain the space. Means somehow we need to treat the dentition to gain the lost space. So where do we do? How do we do the space regaining? Can you see here in this picture? If you see that this permanent molar and this is deciduous D. Now here, it was deciduous E before. This deciduous tooth or E, which is extracted or exfoliated or lost due to any reason, due to loss of this E from this space, what will happen? There is a natural tendency of a molar or of an adjacent tooth to drift into the space. So can you see here, this molar is drifted into the empty space, which is left by deciduous second molar. What will happen when this tooth drifts into this space? The succedaneous tooth, which is a second premolar, the second premolar, which was supposed to be erupted or which is supposed to erupt at its particular time, will not have enough space to erupt into the arch properly. So what will happen? This tooth will have some abnormal eruption pathway. It would be either coming more lingually, it will be erupting buccally, or it will be, causing another type of problems, like it may be causing, if it will not get the proper eruption pathway, then it may cause, resorption of the root of this tooth, or trauma to this tooth, or trauma to the periodontal ligaments of this first premolar. So there can be a lot of problems. So this is the reason that the premature loss, if the tooth is lost due to any reason, maybe it was grossly carious, so it is extracted, it was not properly erupted, we call it ectopic eruption, so that's why it was extracted, or it was lost due to any reason, that is called premature loss of the deciduous second molar due to any reason, can lead to, if we do not treat or we do not give any appliance over here, then there is a natural tendency for the adjacent tooth to drift into the space, and that will cause malocclusion. You see here in this picture, this tooth, the 6th, and this is the deciduous first molar. And here the tooth is drifted into the space because we did not give any sort of appliance, or we did not guide the tooth to be at its place. So that's why it was drifting, or it has drifted into the space which is present adjacent to it. But here you see we have given some sort of appliance over the teeth which are present adjacent to the empty space, which is this space, and this appliance prevent both the teeth, the 6, which was drifted over here, as well as the deciduous tooth, which is present over here, has little tilted. So this appliance prevent the drifting of the teeth in order to maintain the arch space for the tooth which is supposed to erupt into the oral cavity or into this space. So for gaining the space, we need to follow some procedure. One of the procedure is we need to do analysis. we need to analyze how much space is required or how much space will be required for the tooth to have the tooth which is not erupted yet to have its own space into the oral cavity. So there are different analysis to be done. I'm not going to discuss the analysis over here. I'll be making another tutorial for this, but just giving you idea that before proceeding any procedure, first of all, we need to do analysis. How much space to be required for the tooth which needs to erupt into the arch, then we proceed the treatment. As I told you, we are taking the example of this tooth, the 6. Due to early loss of deciduous second molar, these teeth have tendency to drift into the empty space. So what do we need to do once the tooth is drifted? I need this tooth which is drifted into this space. I need this tooth to go back to its original position. So how will I take this tooth back to its original position? I'll be doing it by different ways, by means of some appliance therapy. But before giving any therapy to the patient, as I told you, first we need to carry out the space analysis. After carrying out space analysis, we will plan what type of appliance do we need to give, and then we treat the patient accordingly. So the proper timing, the procedure of taking tooth back to its original position like this 6 back to its original position is called as molar distalization. We are distalizing the molar. See, this is the mesial surface of the molar. It is drifted mesially. We need to take it back distally. So that's why we're calling it distalization. And which tooth are we distalizing? We are distalizing the molar tooth. So that's why it is called as molar distalization. It is said that before the age of 9, the roots of molar are not complete. So it's easier to tip these teeth back or to give a bodily movement to these teeth. But if we do not carry out the treatment at the proper time, see in the definition of interceptive orthodontics, I told you that we carry the treatment at a specific time. Delayed treatment, or when the time has elapsed and you try to do the treatment, you will not get the proper results. Now you just take this example again. You see here the 6 is there, but your 7 is not yet there. Okay, so you can distalize this tooth easily back. But when there is 7 present adjacent to it, or you just see here, I make this 7 means second permanent molar is there. Do you think would you be able to distalize this tooth back? No, you will have hindrance. You will have trouble in taking the molar back or distally. So to do the treatment, try to have a treatment at a perfect time. So that's why I told you that when at the age of 9, the roots of these molars are not well completed, so it's easy to distalize this tooth. Number 2, when the adjacent permanent molar has not yet erupted, means like I'm talking about 7 or second permanent molar, it is again easy to distalize the tooth. The delayed treatment will not give you proper results and it will be rather difficult to carry out. That's why for the molar distalization, the perfect age is 7 to 10 years. Now, we know that the good age for the distalization of the molar is 7 to 10 years. Now the question arises, how do we distalize the molar to regain the lost space? So there are several ways we do. We can do with the fixed appliance therapy. We can do distalization with the removable appliance therapy. I'll be discussing each and every therapy in a detail. I'll be telling you all the appliances, what appliances do we use in the fixed and what appliances do we use in the removal treatment. The appliances which are used for distalization of the molar, number one, are fixed appliances. In fixed appliances, we have several appliances again. Number one is open coil spring regainer or open coil space regainer. That is called hub space regainer also. Another one is called jack screw space regainer. See, again and again we are saying regainer. It means the lost space we are going to regain back. And the third appliance is called jobo space regainer. We'll be talking about each appliance in a detail, that how are they and how can we differentiate between these appliances. Number one is open coil space regainer. We are talking about it in detail. So open coil space regainers, as I told you, they can be called hub space regainers. And these appliances, you see here, which tooth we need to distalize? 6. We need to regain the space back by distalizing 6. And that treatment is called as molar distalization. So the tooth which need to be distalized is to be banded. You see here, a molar band is applied over a tooth, that is 6, which needs to be distalized here in the open coil spring appliance. And can you see here, in these molar band tubes, there is some sort of metal wire crossing, and over that metal wire, you see here, this spring is placed. So this is called open coil space regainer, and these are the components of open coil space regainer, and this works as a distalizer. So number one, we have a molar band which is placed over the tooth, which is 6, the tooth which needs to be distalized. Then over the molar band, we know that there are the tubes which are soldered, which is normally available from the market, the molar band with the soldered buccal tubes. We band the tooth with that, and then we take the tube actually has a diameter of, this is a tube, and this tube has a diameter of 0.25 inch. Tube is actually 0.25 inch long, and it has a diameter wide enough from which our wire, the wire which we need to cross, can easily pass. For example, this is a tube. The tube is open on both ends, and from the center of the tube, a wire will cross. We'll be talking about which wire is this, and that wire will be crossed, and over which we will be applying a spring in order to allow distalization. So first we place the band over the tooth. Then after banding the tooth, which is the tooth which needs to be distalized, if it is on the right side, we apply the tooth need to be distalized on the right side. We place the band accordingly. And if the tooth is on the left side, we will have the band accordingly. The right-sided band cannot be applied to the left side, and the left-sided band cannot be applied to the right side. First of all, we apply the band. Like here, for example, you don't think of this picture, just think of a band. We apply the band in the patient mouth to have an appropriate size of a band first. Then we take the impression as normally we do to make the model. So first we need to apply the band in the patient's mouth, the appropriate size band. When we get, then we take the impression. With the impression, the band will be shifted from the patient mouth. The band will be shifted into this impression you see here. And then afterwards, we do the boring along with the band. So we shall have a proper size of the band copied on the model. Because the same band which we have taken of the appropriate size of the tooth from the patient's mouth, we need to send it to the laboratory to have this appliance fabricated. I hope I'm clear that I'm once again repeating. First of all, you need to take an appropriate size of a band. That band you'll be applying into the oral cavity. After applying into the patient's mouth, you take the impression. Then you pour the model. You will have a model with the band this way. We send this model to the laboratory, and the laboratory will make us this appliance that is called as open coil space regainer. Once this appliance is ready, you see here we have a band that we took of the appropriate size of a tooth. That band is there. We sent to the laboratory, or you can make it by yourself. You take the appropriate size band, then we take a tube, and this is the wire which is going to cross from the tube. So these are the components of this appliance. How will we do that? This band will be applied to a molar tooth, and you see here this tube. This tube, can you see here the picture? The second picture is showing you this tube is placed over here. The tubes are there which are soldered over the molar band. Okay, and this wire that is placed in a way that the ends of the wire are going into the tube of the molar band on both sides, and the wire is given some curve over here. You just look at the anterior part of the wire. The anterior part of the wire is given some U-shaped reverse band. And this U-shaped reverse band will be relying over the first premolar, or in case of deciduous tooth, if it is present, then it will be relying on your deciduous first molar. So this way we fabricate the appliance, we give the appliance to the patient's mouth, and what this appliance will do, that here it will stop the molar from moving into the lost space, as well as it will stop this premolar, or if this premolar is not erupted and here is deciduous first molar, it will also prevent this tooth to drift into the empty space. In order to have them in a position, at the same time, it helps us to regain the lost space. This coil is given. The coil is having spring. This is spring coil, and that coil prevents the distalization or the mesial drifting of the molar, as well as the distal drifting of the first deciduous molar, as well as the first premolar into the empty space. We give this appliance till the second premolar, which is supposed to be into the arch, till this till the second premolar erupts into the oral cavity. As soon as we feel that the tip of the second premolar has reached to the bone, we remove this appliance, because now we know that the deciduous or the second premolar will gain its space itself, or it will erupt into the oral cavity. This is the procedure. Actually, I've already explained to you, so I'm not going to explain it again. You can have a look on it, that how the procedure was carried out. As I told you, first we selected the band, then of the appropriate size, Then we fixed the band into the patient's mouth. Then we took the impression. The band was shifted into the impression. Then we poured the model. After pouring the model, we soldered all the components on the band. Like I told you that we soldered the tube over the band. And after soldering the tube over the band, we passed a U-shaped wire. That wire had some curve. I told you a reverse curve. And we passed a coil, a spring coil. And afterwards, all these components were fixed, and this band was banded over a tooth which was needed to be distalized. Another appliance that is called as jack screw space regainer. You see, there in the first example, or in an open coil space regainer, we had only a molar tooth which was banded. But here, the deciduous molar, if it would have been a deciduous molar, or now here in this picture, it's the first premolar. So this first premolar is also banded because we need to maintain this space for a second premolar to erupt into the oral cavity. So here we used two band. Over there, we used one band. And here, this tooth and this tooth, both are banded. And the banded teeth, this and this, both teeth are banded, which are present to the adjacent empty space. Okay. And there is again a wire, or we can say a nut which is passed, and that lock nut will not allow these both teeth to drift back into the empty space, and it also helps us to regain this space. Again, this is the procedure. Same way, again, we take the bands of the appropriate size as we did in the first open coil spring. The band is selected, the band is selected. After selecting the band, again, we take the impression, the bands get shifted into the model, into the impression, then we make a model. After making a model, we solder the tubes on both of the bands which we have given. After soldering the tubes, we put a lock or a nut, we call it a jack screw. We put the screw inside, and that screw prevent them like this. We put the screw inside, and this screw will prevent them to tilt, and at the same time, this screw will maintain the space which is for the second premolar. Again, this is a discussion of it, as we have already discussed, so I'm not going to waste my time on it. You can have a look on it properly. Another appliance that is called as jobo appliance. This appliance is somehow the appliance that resembles both the appliances which I've discussed early. Only the difference with this appliance is that you do not need any lab procedure with this. Just you fabricate it into the mouth. You shall have an appropriate size of a molar band. After having appropriate size molar band, you take the wire, you take the wire. First of all, you make a U shape of the wire. Then once you make a U shape on the wire, then you solder both ends of the wire with the molar band, and once this is soldered with the molar band, you take this molar band into the patient's oral cavity and cement it. That's it. The function and the action is same as we discussed before of these two appliances, the open coil spring and the jack screw. All have the same function of distalizing the molar. So that was all about the fixed appliances. We can have removable appliances. to treat such case or to regain the space by distalizing the teeth. So number one, we have the appliance, which can, in the removable appliance, we can have several appliances for upper and lower arch. That is called, if used in the upper arch, we can call it upper hollis appliance. If used in the lower arch, we can call it a lower hollis appliance. These plates are called as hollis appliances. What do we give to these appliances to distalize the tooth? We give this screw. Can you see here? Springs. These springs are used in these appliances to distalize the tooth. Can you see here? This is one spring on this side and this is the spring on the other side. That is called as helical spring or a finger spring that is incorporated into this appliance, and they prevent these teeth from drifting into the empty space, as well as they help us in regaining the lost space. Another type of appliance, that is again hollis, because removable appliances we use are usually hollis appliances. This hollis appliance was with the helical spring, as I told you here. This hollis appliance, another way to fabricate the hollis appliance, they fabricate the same plate as like here, but they split the plate from here. Split. You see here the split, this is splitted. So we split the plate. So that's why it is called as hollis split acrylic plate with a dumbbell sort of spring. You see the shape of a spring is like a dumbbell. So that's why we are calling it hollis appliance with a dumbbell spring, but that is a split plate. Similarly, we have another hollis appliance with the slingshot elastic. You see here, same plate, but there is no spring used, but some elastic is used. Another hollis appliance with the palatal spring, as this was actually a hollis appliance with the palatal spring. You see, the springs are coming from the palatal side. That's why we are calling it hollis appliance with a helical spring or a palatal spring. Another appliance type is hollis appliance with the expansion screw. This is actually a hollis appliance with the screw, and this screw is called as expansion screw. We'll be talking about each appliance in a detail. So upper and lower hollis appliance with a helical spring, as we said, that we give, if in the upper arch, we call it at upper arch hollis appliance. If we give in the lower arch, we call it a lower arch hollis appliance. This hollis appliance is having some components. This is the acrylic work that is called as base plate. This appliance has Adam's clasp for its retention. We need to have retention of this plate into the arch, so we need some retainers, and these retainers are called Adam's clasp. They help us in retaining the appliance into the oral cavity, as well as the labial bow. Labial bow is also used in this appliance. It gives us two advantages, or it helps us in two ways. Number one, it gives retention. Also, if there is a little proclination, it can treat the proclined teeth at the same time. And we have a spring here. You see, both sides, the deciduous, there is early exfoliation of the teeth. So on both sides, we have given the springs, or single coil springs or a finger springs. These appliances are removable type of appliances, means they can be easily worn by the patient or they can be removed by the patient. We can use, instead of a single coil spring, you see a single coil is there. We can use double coil spring also. But the indication of double coil spring is different in different conditions, but it also depends upon the expertise of a dentist, that how the dentist is going to make it and how the dentist is going to achieve the space back. I hope I'm clear about the hollis appliance with the helical spring. This is the helical spring. As I told you, we can make a single coil. If we make a single coil, we call it a single cantilever or single helix. Helical spring. If there are double helix, so we call it a double helical spring. And they help us to regain the space back. Application of excessive forces. If we apply more forces with these springs, then the increased forces or high pressure may produce necrosis of the ligaments, of the periodontal ligaments which are encircling the tooth. So improperly designed appliance or improperly designed springs may cause necrosis, number one, because of the excessive pressure, or they may displace the tooth, or they may displace themselves in an abnormal position. So before fabricating these appliances, a dentist shall be very careful that there should not be any excessive force generated by the spring, and the spring shall be made appropriately, that it should neither displace itself nor it displaces the tooth in abnormal direction. Why do we make this helix? You see here, the purpose of making a helix, for example, this is the wire. I have made this helix on it. What this helix will do? Normally, if I don't make the helix, the wire is like this. You see here, making a helix increased the length of the wire for me. You see here, this much of the wire. With the helix, the additional wire is bent, and I had an additional piece of a wire. So I can do adjustment without any pressure. I can open this. I can close this helix by means of some particular instrument. Usually we use 3-prong plier. So why have we made this helix? This helix actually allow us to work efficiently. We can, if I increase I open this coil. Once I open the coil, you see, if I try to, this is the diameter of a coil right now. For example, I need to open this coil. Don't you think the coil will be a little like this? Increased. The coil diameter is increased. As soon as the coil diameter increased, can you see here this retentive arm or active arm? This active arm is reduced in length. At the same time, if I close the coil, you see here, this was the coil before, and I have closed the coil. As soon as I closed the coil, this diameter reduced and this active arm became increased in length. So the purpose of giving a spring is that we can have a good play with the wire. Whether we need to move the tooth more distally, we close the coil. We close the coil so that this active arm will increase in size and it will distalize the tooth more will take the tooth more distally. So that is called as activation of appliance. This is how we activate the appliance. So how do we do activation of the appliance? By working on a helix. Number one, when and how do we do activation of the appliance? According to literature, during the first week of treatment, helix should be adjusted by giving a distal directed pressure, because we need the tooth to be distalized, okay? So that's why the pressure should be distally directed. After 2 weeks or after the interval, after the first week, when the patient comes to us, we recall the patient and we need to again adjust the spring, because when, for example, here in the first week, this was the tooth which is present over here. the helix we activated, and it was taking tooth like this here. When the patient came to us after some time, this tooth is little directed distally. You see here, you just take this example. The tooth, can you see it was earlier here? Now the tooth is distalized a little. So once the tooth is distalized, it means you need to activate the appliance again, because now the appliance is away from the tooth. Again, you see here, the appliance is over here. It's not applying any pressure over the tooth. Let me draw it again to be more clear. You see, this was the first time when the patient came to us. Now, after a week of activation, the patient has come to me or you. We need to activate the appliance. What is the purpose of activating the appliance? Because we need the appliance to efficiently work on the tooth. You see here, now the tooth is, it was here before. Now the tooth is distalized a little and it is gone over here. The appliance which was given before on this tooth was attaching the tooth. It was in contact with the tooth. But now in this condition, do you think this appliance will be in contact with the tooth? No, it is away. We need this appliance to contact this tooth and to distalize it more. So that's why we recall the patient after some interval and we keep on activating the appliance to have more distalization of the tooth. According to literature, we can distalize the tooth around 2 mm in 2 to 4 months. Make this point clear that we are treating the patient with removable appliance. We are not treating the patient with fixed appliance. So the removable appliance takes longer to distalize the tooth. If it would have been a fixed appliance, then the distalization or the result would have been achieved earlier. As I told you before, that was the hollis appliance with the helical spring. Another hollis appliance, which I told you that in which we gave the hollis appliance same acrylic plate, we gave the same labial bow, we gave the same Adams clasp, but the difference was that over there we used the spring, but here we are not using the spring, but we are using the spring, but not a helical spring. We are using a dumbbell type of a spring. This type of a spring we are using. Number 1 and number 2, here we have split the plate. The purpose of splitting the plate is, you see here, one part of the plate is here and other part of the plate is here. This appliance, which is called as a dumbbell appliance, is going this way from both ends and the plate is somehow joined by means of this dumbbell appliance. So when we will be activating the appliance, not only the appliance will be widened, but at the same time, the plate, which is split from the center, will be taken apart. When the plate will be taken apart, it will again activate, it will be the activation of the plate and it will be distalizing the tooth. So with these distalizing appliances or with this acrylic plate, split acrylic plate with a dumbbell appliance, you can again regain the lost space of around 2 mm because again it's a removable type of appliance and it helps tipping. Number 1. Number 2, mind one thing. With the removable appliances, we get tipping movement. We don't get bodily movement with the removable appliances. Means tipping, and there is a difference between tipping and bodily movement. With the fixed appliances, we get the bodily movement, means whole the body of the tooth from here till here, I can distalize. A whole length of the tooth when distalized is called bodily movement. But what is a tipping movement? Like the tooth is here. These are the roots of the teeth. A tooth is tipped. Not whole the body of the tooth is moved. A tooth is tipped. So with the removable appliances, we get tipping movement. So the removable appliances are a little slower to give us the movement. They give us the movement of around 2 mm, 3 mm, but in a longer period of a time. Whereas if we go for the fixed appliances, they give us quick results. So how do we activate this dumbbell appliances? Again, by opening the spring. As I told you, by opening the spring. By means of some particular instrument, we try to open this spring. Opening the spring will ultimately open this acrylic plate, and as you see here, the one end of the plate along with the appliance is pushed over here, the other end of the plate along with the appliance is pushed over here. So what will happen when it will be pushed? Ultimately this tooth will be pushed distally. Okay, I hope this is clear to you. Another type of appliance that is again a hollis appliance, because we are discussing about the removable one, but this appliance is having some hooks and we are using some elastic. So that's why we are calling it a hollis appliance with a elastic. We call it a slingshot elastic. You see here, again the same plate, acrylic plate. We have an Adams clasp. You see here in this acrylic plate, we have incorporated some hooks. And those hooks, I'll click this hook. And there is another hook. You see here, this hook is placed near the molar tooth, which is needed to be distalized. And there is another hook which is present on the mesial side of the space. Here you don't consider here the tooth is present. You see here the space is empty and we do not want this tooth to drift into the empty space. So both the teeth which need to be, held in a position, they are to be applied with the hook like this here, this tooth and this tooth. The hook is applied and an elastic is crossed from both of the hooks. And this elastic will apply force. This elastic from here till here, which is given, it applies a force. This force on one hook from here on the lingual side of a molar tooth, here this elastic is placed and another elastic is placed over here. But over here, actually, we are supposed to place the elastic to hold the teeth into the position. But another elastic is applied from the buccal side. This, you take the example of the tooth. On lingual side, a hook is applied, and also there is another hook soldered over here. So an elastic will be crossed from here till the paralingual surface of a tooth and will be going to the other side of a tooth in order to hold the tooth, not to allow the tooth to rotate or to drift into the empty space. Means the elastic is applied on the same molar on both sides in order to prevent this molar to drift into this space or into the empty space where our premolar is supposed to erupt. Another appliance that is called as hollis appliance with the palatal spring. It is same hollis appliance with the spring as we discussed before. The purpose of explaining it over here is that we are giving the appliance or a spring on the palatal side. So that's why we are calling it a hollis appliance with a palatal spring. The activation of this appliance is same as we discussed before, the hollis appliance with the spring. Now, The hollis appliance again with the expansion screw. You see here, the designing is same, but we did not incorporate springs over here. We did not incorporate any dumbbell kind of appliance over here. Rather, we are giving some kind of screws over here. So this is called as expansion screws. These are more effective than these finger springs or double, helical springs or dumbbell springs. So these appliances are having more effect, like because of the spring, the activation is more and we can achieve the results quite earlier. The springs which are used over here in this, again, same acrylic plate, we will have, again, the acrylic plate will have a split in between. Then between these two split ends, this appliance will cross, that is called as expansion screw. This expansion screw has this hole, and this hole is the one where by means of this key, we do the activation, like over here. This screw is applied at the center of the palate. So I'm not going to discuss about it. It has some different action. It does help in distalization, but it rather helps more in expansion. So we are not talking about this picture more. I'm going to discuss this picture, that this screw has this, you see here, a hole. By means of the key, we do the activation. When we try to move this screw by means of a key, these both parts of the screw gets apart. At the same time, the plate which is split at the center get apart, and similarly we will have a distalization of the molar, as well as little, if this premolar has migrated into the space, it will have a mesial migration and we can gain the lost space. We can regain the lost space. There are other kind of screws we can use. There can be mini screws used. This screw is called as expander, or we can call it a expansion type of a screw. It is it is causing distalization by expanding the arch. So that's why we are calling it a expander. And we can have another type of screws. These are called as eccentric screws, or there are some special screws. So this is the way we regain the space by distalizing the molar tooth, which has taken the space of a future premolar tooth which was supposed to erupt, and we need to regain the lost space. We have several methods of gaining this space. There are other type of screws available in the market. It depends upon the dentist, which screw he wants to use, in which condition the screw is needed to be used, and what is the indication of the particular screw, whether it is used in the maxillary arch, whether it is used in the mandibular arch, whether we need a small size screw, whether we need a large size screw, whether we need a distalization screw, whether we need the expansion screw, how much turn do we require, how much expansion do we require. That all depends upon the case, which case are we dealing with, and how much space do we require. So I told you the methods, one of the method